Okay. Ever had that feeling, maybe after a really long flight or even just a long car ride, where you take a deep breath and it just feels off?
Mm-hmm.
Or maybe a sudden sharp chest pain makes you stop and think, whoa, what just happened?
Yeah, those moments can be pretty scary. And they could potentially be related to what we're diving into today, pulmonary embolism, or PE.
Exactly. And we know you're here, listener, dedicating this time to really get PE nailed down for your revision. So that's our mission today.
Right. We want to take this, potentially complex topic and really break it down, make it digestible, focus on the high-yield stuff you absolutely need. We'll guide you through it.
Perfect. Yeah, we've got some really comprehensive notes here covering everything from the basic definition all the way through to potential complications.
The goal is really to pull out those key nuggets, make it efficient for your learning, build that solid understanding.
So let's lay out the map for this deep dive into PE. We'll start with the definition. What actually is it?
Then we'll look at where it comes from, the etiology, and who's most at risk of the risk factors.
Then get into the mechanics, right? What's going wrong inside the body, the
Yeah,
pathophysiology.
exactly. And also, what else could it be confused with? The differential diagnoses, plus how common is it? We'll touch on the epidemiology.
And then the really practical stuff. How does it present? Clinical features. How do doctors figure it out? Investigations.
How is it treated, management? What's the outlook, prognosis? And finally, those potential complications.
We'll try and weave in some ways to help remember things too. Maybe think about how questions might come up. Sound good? Ready for the deep dive?
Absolutely. Let's kick off definition first. So, pulmonary embolism. Fundamentally, it's a life-threatening condition. That's the first thing to grasp.
Life-threatening because...
Because it involves a blockage in the pulmonary arteries, the vessels carrying blood to your lungs.
And these blockages, they don't usually start in the lungs, do they? They travel there, like debris blocking a pipe downstream.
That's a great way to think about it. And yeah, the vast majority originate elsewhere. Usually it's the deep veins of the legs. We call that deep vein thrombosis, DVT.
Specifically the bigger veins, right? The proximal ones.
Exactly. The proximal veins of the lower extremities. So a clot forms there, maybe silently.
You might not even know it's happening.
Precisely. Then a piece breaks off, travels through the bloodstream up towards the heart, and then gets pumped into the lungs where it gets stuck in those smaller pulmonary arteries.
Causing an obstruction, backing things up.
Right. And that obstruction immediately impacts blood flow to the lungs, which means trouble getting oxygen into your blood.
And it's not always a massive event, is it? There's a range.
Crucially, yes. It's a spectrum. You can have small PEs that might cause minimal or even no symptoms, asymptomatic, right up to what we call massive PE, which can cause collapse and be fatal very quickly.
Okay, definition clear. Let's move on to the why, the etiology. What causes these clots to form in the first place, down in those deep veins?
Well, as we said, the main event is a DVT forming and then embolizing, traveling to the lungs. And there are several factors that make clot formation more likely. You might remember Virchow's Triad.
Ah, yeah, vaguely. It's about blood flow, vessel walls, and the blood itself, isn't it?
Exactly. So think about situations that affect those things. Stasis or slow blood flow. That happens when you're immobile for long periods.
Like that long flight we mentioned, or being on bed rest.
Precisely. Immobilization is a big one. Then there's damage to the vessel wall. Surgery, especially major surgery or a significant trauma, can do that.
And the surgery itself, plus the recovery, probably involves immobilization too, right?
Often, yes. Double whammy sometimes. Surgery and trauma can also trigger the body's clotting cascade more generally.
Okay. What else makes the blood itself more likely to clot? Hypercoagulability.
Right. Things like active cancer can do that. Certain conditions make the blood stickier. Also, hormonal factors play a role to pregnancy, particularly later stages and postpartum.
And things like the contraceptive pill or HRT?
Yes. Oral contraceptives and hormone replacement therapy are known risk factors. Lifestyle factors, too. Obesity is one, smoking is another.
How does smoking increase risk?
Smoking damages the endothelium, the lining of the blood vessels, making clots more likely to form. Obesity can affect circulation and promote a low-grade inflammatory state.
And genetics. Some people are just more prone.
Yes, there are inherited thrombophilias, like factor V Leiden mutation or prothrombin gene mutations, that predispose people to clotting. And other medical conditions, too, like antiphospholipid syndrome or certain blood disorders called myeloproliferative disorders.
So mostly DVTs from the legs. Any other less common starting points?
Occasionally, clots can come from deep veins in the pelvis or even the upper arms. Very rarely, a clot might form directly in the right side of the heart and travel from there. But legs are the main source.
Got it. That gives us a good picture of the causes. Now, let's zoom in on who is actually most likely to get a PE, the risk factors.
Okay, it's helpful to group these. First off, if you've had a VTE, that's venous thromboembolism, so a DVT or PE before, your risk is significantly higher.
Yeah.
History matters.
Like lightning striking twice.
Kind of, yeah. The underlying predisposition might still be there. Then, as we just discussed with etiology, prolonged immobility is a major one. Think bedrest, long travel.
Surgery and trauma, again, especially major stuff, abdomen, pelvis, hip or knee replacements.
Definitely. Those are high-risk procedures.
Um,
And significant trauma in general. Active cancer or even a recent history of cancer is another really important one.
and you mentioned pregnancy.
Yes, obstetric factors are key. Late pregnancy, the period right after birth, the puerperium, having a C-section, these all increase risk. Remember, pregnancy presses on pelvis, promoting PE, maybe a bit simplistic, but it helps link it.
Hormonal therapy, we've covered OCPs, HRT, smoking, obesity.
Yep, those are on the list. Age is the factor too. Risk increases as you get older.
What about inherited clotting disorders, the promophilias?
Absolutely, those predisposed individuals. And other medical conditions like heart failure or chronic lung disease can contribute. They put extra strain on the system.
Makes sense. What about problems specifically with the legs?
Yeah, things like a lower limb fracture or even significant varicose veins can impair flow locally. And generally reduced mobility, say being hospitalized or in a care home, is a risk factor across the board.
Any others we should mention?
IV drug use can damage veins. Spinal cord injury leads to immobility. Central venous lines can be a site for clot formation. Certain blood disorders, again, thrombotic disorders, myeloproliferative disorders, and even some kidney conditions like nephrotic syndrome, being on dialysis, or PNH.
Wow, okay, it's quite a list. But many seem to connect back to those Virchow's triad ideas, sluggish flow, vessel damage, or stickier blood.
Exactly. Understanding the why behind the risk factors helps it stick. And knowing these helps us identify people who might need prevention or have a higher index of suspicion if they develop symptoms.
Right. So we know who's at risk. Let's get into the how. What actually happens physiologically when that clot lodges in the lungs? The pathophysiology.
Okay, the core issue is that physical blockage of the pulmonary artery, or arteries. This directly reduces or stops blood flow downstream from the clot.
And the lungs are all about gas exchange, so blocking blood flow messes that up.
Precisely. You get what's called a ventilation-perfusion mismatch, or VQ mismatch. You've got air getting into parts of the lung ventilation, but blood isn't flowing properly to pick up the oxygen and drop off the CO2 perfusion.
So oxygen levels in the blood drop, hypoxia.
Yes, hypoxia is a major consequence.
Yeah.
And potentially carbon dioxide levels can rise hypercapnia, though often the body tries to compensate by breathing faster, which can initially lower CO2.
And blocking the pipes puts pressure on the pump, right? The heart.
Absolutely. The blockage increases the resistance the right ventricle has to pump against. Pulmonary artery pressure goes up, the right ventricle has to work much harder.
Which can lead to
Right heart strain. You can see signs of this on ECG or echo. If it's severe or prolonged, it can progress to right heart failure. The right ventricle just can't keep up.
And in the worst case scenario, massive PE.
In massive PE, the blockage is so significant that the heart's output drops dramatically. This leads to systemic hypotension, low blood pressure, and poor perfusion of vital organs. That's cardiogenic shock, a real emergency.
That really clarifies the cascade of problems a PE can trigger. Okay, so someone comes in, maybe breathless, maybe with chest pain. It could be PE, but what else needs to be on the radar? The differential diagnoses.
That's super important because PE symptoms can be really nonspecific. Top of the list, especially with chest pain, is acute coronary syndrome, a heart attack. You have to rule that out.
Makes sense. What else? Lung things.
Yeah, pneumonia, a lung infection can cause shortness of breath, cough, maybe chest pain. Pleurisy inflammation of the lung lining causes that sharp breath-related pain, which can mimic PE.
And collapsed lung. Pneumothorax.
Definitely. Sudden onset breathlessness, chest pain. Can look similar initially. Even things like anxiety or a panic attack can cause rapid breathing, palpitations, shortness of breath.
Musculoskeletal pain, like pulling a muscle in the chest wall.
Yes, that can cause localized chest pain, sometimes sharp. Need to differentiate it. And other heart issues too, besides ACS.
Such as?
Well, heart failure can cause breathlessness, though often more gradual. Aortic dissection, a tear in the big artery from the heart, causes severe, often tearing chest pain. Cardiac tamponade fluid around the heart, squeezing it, causes breathlessness, low blood pressure.
And even something systemic like sepsis.
Sepsis can present with tachycardia, tachypnea, hypotension features that overlap with severe PE. So yeah, always need to keep a broad differential in mind.
Good reminder. Okay, let's switch gears slightly. How big a problem is PE in the UK? What's the epidemiology look like?
It's a significant issue, a major cause of morbidity, illness, and mortality death. Estimates suggest around 50 to 100 cases per 100,000 people each year in the UK.
That's quite a few people. And mortality.
The numbers are stark. Estimates for England and Wales suggest somewhere between 30,000 and 40,000 deaths attributable to VTE, including PE, each year. It really highlights the seriousness.
Wow. Does it affect certain groups more? Older people?
Yes, the incidence definitely increases quite sharply with age. It affects both men and women, though there might be slight variations depending on age and other factors. But fundamentally, it's a risk across the adult population, especially older adults.
Those numbers really drive home why understanding PE is so vital. Okay, clinical features. How does someone with a PE typically present? What are the classic signs and symptoms?
The absolute classic is sudden onset dyspnea, shortness of breath. Just comes on acutely, often accompanied by pleuritic chest pain, that sharp pain, worse on taking a deep breath or coughing.
You might see them breathing fast, too. Tachypnea.
Yes, tachypnea is common, and tachycardia, fast heart rate. A cough can be present, sometimes, though less commonly they might cough up blood that's hemoptysis.
And feeling faint.
Yes, syncope, actually fainting or near syncope, feeling like you're about to faint, can definitely happen, especially with larger PEs. So maybe think of the classic five: sudden breathlessness, pleuritic pain, fast breathing, fast heart rate, maybe cough hemoptysis.
Okay. And when a doctor examines them, what might they find?
Well, they'll likely confirm the tachypnea and tachycardia. They might observe cyanosis, a bluish tinge to the skin or lips, indicating low oxygen. Pulse oximetry would show hypoxia, low oxygen saturation.
Any signs related to that right heart strain we talked about?
You might see elevated jugular venous pressure, the neck veins looking distended. You could hear heart rhythm abnormalities like new AF. Sometimes a pleural rub, a grating sound heard over the lungs with a stethoscope.
And in severe cases?
Signs of shock, low blood pressure, systemic hypotension, cool peripheries, confusion, cardiogenic shock.
So faced with these symptoms and signs, how do doctors stratify the risk? You mentioned scoring systems earlier, Wells criteria.
Exactly. The Wells criteria for PE is a really useful tool to estimate the pre-test probability, how likely is PE, before we do definitive tests. It assigns points for different clinical features.
Can you remind us of the main ones?
Sure. Sign symptoms of DDT, like a swollen tender leg, that gets 3 points. If PE is considered the most likely diagnosis by the clinician, or equally likely as others, that's another 3 points. Heart rate over 100 BPM is 1.5 points. Recent immobilization or surgery within 4 weeks is 1.5 points. A previous DVT, or PE, is 1.5 points. Hemoptysis gets 1 point, and active malignancy gets 1 point. There's a mnemonic, maybe clue-sham clinical DVT, likely diagnosis, elevated HR, immobilization surgery, history of VTE, hemoptysis, malignancy, but remember the points vary.
Okay, add up the points. Then what?
If the total score is 4 or less, PE is considered unlikely. If it's more than 4, PE is likely. And this guides the next steps.
And there's another rule-out tool, PERC.
Yes, the Pulmonary Embolism Rule-Out Criteria, or PERC. This is specifically for patients where you already have a low clinical suspicion, say, less than 15% chance of PE.
And if they meet PE?
It's actually the opposite. If they meet none of the PERC criteria, all 8 are negative, then the chance of PE is extremely low, less than 2%, and you can often safely rule out PE without further testing like D-dimer or imaging.
What are those 8 criteria? Quick rundown.
Okay, age under 50, heart rate under 100, oxygen saturation 94% or higher, no prior DVT PE, no recent surgery trauma needing hospitalization, last 4 weeks, no hemoptysis, no unilateral leg swelling, and no estrogen use. If the answer is no to all of these in a low-risk patient, PERC is negative, maybe low HPPS, no leg swelling or estrogen.
Helpful for avoiding tests in low-risk folks. You also mentioned a 2-level Wells score.
Yeah, it just simplifies the interpretation. Score 4 is PE likely. Score area 4 is PE unlikely. Likely often means going straight to imaging like CTPA. Unlikely usually means checking a D-dimer first.
Well, we need to remember sometimes the symptoms aren't classic at all, right? And severe cases can just present with collapse.
Absolutely critical point. Non-specific symptoms are common. A high index of suspicion is key, especially if risk factors are present. And sadly, yes, sudden collapse or death can be the first presentation.
Okay, we suspect PE based on clinical features and maybe risk scores. How do we confirm it? Let's talk investigations.
Right. The workup usually involves blood tests and imaging. A key initial blood test is the D-dimer.
Which measures clot breakdown products.
Exactly. It's very sensitive. If the D-dimer is negative in a patient deemed PE unlikely by Wells score, it's very good at ruling out PE.
But it's not very specific. Lots of things can raise it.
Correct. Infection, inflammation, surgery, trauma, cancer, pregnancy, even just older age, can elevate D-dimer. So a positive result doesn't confirm PE. It just means you need to investigate further. We sometimes use age-adjusted D-dimer levels for older patients to improve specificity a bit.
So if D-dimer is positive, or if the patient was PE likely to begin with, what's next? Imaging.
Yes. The gold standard, well, the recommended first-line imaging test for most suspected PEs is CT pulmonary angiography, CTPA.
That's the CT scan with contrast dye.
Precisely. The contrast highlights the pulmonary arteries, allowing radiologists to directly see any clots. It's very effective at confirming or excluding PE, like a detailed map showing roadblocks.
What if someone can have a CTPA? Maybe kidney problems or a contrast allergy?
Good point. In those cases, a ventilation perfusion scan, or VQ scan, is the main alternative.
How does that work again?
It compares airflow, ventilation, using an inhaled tracer, with blood flow perfusion, using an ejected tracer. A mismatch in area that's ventilated but not perfused suggests a blockage, a PE. It's particularly useful in pregnancy sometimes, or younger patients, due to lower radiation dose to the chest compared to CTPA. Its sensitivity is decent, around 75%, and specificity quite high, maybe 97%.
What about a plain old chest x-ray? Is that useful?
It's usually done, but often it's normal in PE. Its main role is to rule out other things like pneumonia or a pneumothorax. Occasionally, you might see subtle signs like a wedge-shaped shadow, Hampton's hump, or decreased vessel markings, Westermarck sign, but they're not common or specific.
And an ECG. We mentioned signs of right heart strain.
Yes, an ECG is standard. It might show sinus tachycardia, new atrial fibrillation, signs of right ventricular strain, like T-wave inversion in leads V1, V4, or the S1Q3T3 pattern, though that's classic but not very sensitive or specific, or a right bundle branch block. It helps assess severity and rule out cardiac causes.
Echocardiogram, the heart ultrasound.
Echo is really valuable for assessing right heart function. It can show if the right ventricle is dilated or struggling, which supports a significant PE. Sometimes you can even see the clot itself in the main pulmonary arteries or right heart, but its main role is assessing the hemodynamic impact.
Any other blood tests? Troponin.
Yeah, troponin might be checked. If it's elevated, it suggests some degree of heart muscle strain or injury due to the PE, which can indicate a more severe case. Other baseline bloods like full blood count, urea and electrolytes, and a clotting screen are routine. Arterial blood gases might be done in sicker patients, often showing low oxygen and maybe low CO2 initially due to hyperventilation.
And if you suspect a DVT, it's also present.
Then a leg ultrasound Doppler is definitely indicated to confirm that.
So, summarizing the approach. Assess clinical probability. Wells. If unlikely, maybe D-dimer if likely, or D-dimer positive, then usually CTPA with VQ as an alternative, and PERC for the very low-risk group.
That's the general pathway, yes.
Yeah.
Balancing diagnostic accuracy with avoiding unnecessary tests. But always remember, clinical judgment trumps scores. If you're still worried despite negative tests, you might need to rethink or repeat investigations.
Okay, diagnosis sorted. Now, management. Someone has a confirmed PE. What's the treatment strategy in the UK?
The main goals are crucial. Stop the clot getting bigger, prevent new clots forming, stabilize the patient, and minimize complications, both immediate and long-term. The absolute cornerstone is anticoagulation blood thinners.
Which ones are typically used? Heparin, warfarin?
Traditionally, yes. Often starting with heparin, usually low molecular weight heparin, LMWH, given by injection, sometimes as a bridge to warfarin, which takes a few days to work and needs INR monitoring.
But things have shifted more towards the newer drugs, right? DOACs.
Absolutely. Direct oral anticoagulants, DOACs like apixaban, rivaroxaban, edoxaban, dabigatran, are now recommended by NICE as first-line treatment for most patients with PE.
Why the shift?
They're generally as effective as warfarin, but much more convenient. Fixed doses, no routine blood monitoring needed like the INR for warfarin, fewer food and drug interactions. So for most people, they're the preferred option now.
What about really severe cases? The massive PE with shock. Is just anticoagulation enough?
No, in those high-risk hemodynamically unstable patients, more aggressive treatment is needed urgently. That's where thrombolysis comes in.
Clot-busting drugs.
Exactly. Drugs like alteplase are given intravenously to actively dissolve the clot quickly and restore blood flow. Oxygen therapy is vital too, aiming for SATs usually 94–98%.
Are there situations where anticoagulants can't be used? What then?
Yes. If there's active major bleeding or a very high risk of bleeding, anticoagulation might be contraindicated. In those rare cases, or if PE recurs despite adequate anticoagulation, an inferior vena cava IVC filter might be considered.
That's a little basket filter put in the big vein in the abdomen.
Right. It aims to catch clots traveling up the legs before they reach the lungs. But they have their own risks, like causing clots themselves, so they're used selectively and ideally removed later, if possible.
What about general supportive measures?
Pain relief is important, especially for pleuritic pain. Close monitoring of vital signs, encouraging early mobilization once stable, and compression stockings can help prevent further DVTs.
How long do people stay on anticoagulants?
That depends. If the PE was provoked by a clear, temporary risk factor like surgery or immobilization, treatment might be for 3–6 months. If it was unprovoked, meaning no clear trigger, or if risk factors persist, like active cancer, treatment is often longer term, sometimes indefinitely, after weighing risks and benefits.
Is surgery ever an option to physically remove the clot?
Surgical embolectomy is reserved for very specific situations, usually high-risk massive PE where thrombolysis failed or is contraindicated, or sometimes for intermediate high-risk PE with concerning features, or clots actually lodged in the right heart. It's major surgery.
You mentioned massive PE needs urgent action. What's the immediate drill?
Immediate resuscitation ABC approach, high-flow oxygen, secure 5E access, urgent consideration for thrombolysis. Starting intravenous heparin is also usual decisions are made. It's an emergency.
And pregnancy. That must be complex.
Very. Risk of VTE is higher. Interpreting symptoms like breathlessness is harder. Sadly, PE is a leading cause of maternal death, especially postpartum. Treatment usually involves LMWH injections throughout pregnancy and postpartum, carefully balancing maternal and fetal safety. DOACs are generally avoided in pregnancy.
And nice guidelines. They really push for DOACs and maybe even outpatient treatment for some.
Yes. Nice guidance reflects the evidence favoring DOACs first line for most. And there's definitely a move towards treating selected, low-risk, stable PE patients as outpatients, which avoids hospital admission. They also stress VTE prevention in hospitals, risk assessment, and regular review of anticoagulation.
Seems like management is quite refined now. What about the long-term outlook? The prognosis after a PE?
Prognosis really varies. It depends heavily on the size of the clot, how sick the patient was initially, their underlying health and risk factors, and crucially, how quickly and effectively he was treated.
So prompt diagnosis and treatment are key for a good outcome.
Absolutely paramount. The sooner treatment starts, the better the chances. There are factors that predict poorer outcomes, though, things like being older, say over 70, having cancer, underlying heart failure or COPD, presenting with low blood pressure or high respiratory rate, or having signs of right ventricular dysfunction on echo, these suggest a more severe impact.
But for many people, if it's caught and treated properly, they do okay.
Yes, the majority of patients diagnosed and treated appropriately for PE have a good prognosis and make a full recovery. But it's not guaranteed.
What are the potential negative outcomes if things don't go well or treatment is delayed?
Well, the most immediate risk is death, especially with massive PE. Long-term, the main worry is chronic thromboembolic pulmonary hypertension, CTEPH. Recurrent PE is also a risk, and ongoing right heart strain or failure.
Okay, let's finish by looking specifically at those complications. You just mentioned CTEPH.
Yes, chronic thromboembolic pulmonary hypertension. This is where the clot doesn't fully dissolve but organizes into scar tissue in the pulmonary arteries, causing persistent high pressure in the lungs and leading to progressive breathlessness and right heart failure. It's a serious long-term complication needing specialist management.
And recurrence.
Yes, having had one PE puts you at higher risk of another one, especially if anticoagulation is stopped or underlying risk factors persist.
We talked about right heart strain failure as part of the acute process. Can that persist?
It can, particularly if there was significant damage initially or if CTEPH develops. Respiratory failure is a risk in the acute phase too.
Other things.
Pulmonary infarction, where a bit of lung tissue dies due to lack of blood flow, can happen, causing pain and sometimes hemoptysis. Pneumonia can complicate things. If the PE came from a DVT, You might get ongoing leg problems like post-thrombotic syndrome, chronic swelling, pain, skin changes, and of course the treatment itself, anticoagulation, carries a risk of bleeding complications.
So PE isn't just a one-off event. It can definitely have lingering effects.
That's right. Follow-up is important to monitor for these potential long-term issues.
Right. Well, that brings us towards the end of this really comprehensive deep dive into pulmonary embolism. We've covered a huge amount.
We have, from defining it, understanding the risks and causes, through to recognizing symptoms, the diagnostic pathway, and the various management strategies.
Key takeaways for me are definitely its potential severity, the absolute importance of recognizing risk factors, and those classic, sometimes subtle symptoms.
And the advances in diagnoses like CTPA and treatment, especially the shift towards DOACs, which have really changed the landscape for many patients.
And hopefully for you listening, breaking it down like this, section by section, has given you that clear, structured overview you need for revision. The structure itself, the mnemonics we mentioned, they're all tools to help it stick.
Absolutely. And maybe a final thought to leave you with. Consider the ongoing research in VTE. Things are always evolving, better risk stratification, refining treatment durations, understanding long-term outcomes like CTED. It always comes back to that careful, individualized patient assessment.
That's a great point. And if you are looking for more resources specifically for MSRA preparation, do check out passthemsra.com.
And also freemsra.com, those excellent resources.
So keep reviewing PE. It's such a crucial topic. Keep asking questions.
And we wish you all the best with your continued learning and your exams.